Hey, good morning, everybody. This is Brittany Jennings coming to you live from Seniors Blue Book. And today we are doing the Doc Talks segment, and I have Dr. Omar Henriquez from Family Spine and Pain Care Institute. Good morning, Dr. Omar.
Good morning. Thank you for having me.
Happy to have you here today. And how's everything going for you?
Good. It's going well. It's been very busy, even in these times with COVID and everything. Patients have pain, and pain has to get taken care of. So it's been busy, but everything's been done in a safe manner, and it's been good. It's been great.
So I'm excited to have you today because we're going to talk about how to treat sciatica pain. But first, tell us a little bit about Family Spine and Pain Care Institute.
Sure. So Family Spine and Pain Care Institute is an interventional pain clinic that basically takes care of all types of pain, not only sciatica, but arthritis, shoulder, knees, chronic headaches. And part of what sets us apart from other places is how we treat our patients and the fact that we like to educate. So we like a lot of our patients to understand their situation and to really understand how the treatment works, because we see that most patients end up doing a lot better when they understand and are also heard, right? And so that's our philosophy, and we just like everyone to feel welcomed, and I don't want anyone feeling rushed basically when they come in.
Absolutely. It's so important. And I love that that's your philosophy, because that's how anybody wants to be treated, like family. So love that. Let's go ahead and jump into how to treat sciatica pain. I know a lot of people do suffer from this on a daily basis, so I think this is a great topic for you to shine some light on.
Sure. So first, what is sciatica? Sciatica is basically pain that comes from the spine but radiates into other places. So if you have pain kind of shooting down the leg, let's just focus on the lower back, right? So if you have pain shooting down the leg, a lot of patients will say, look, I don't have any back pain, but I do have leg pain. I do have gluteal pain. Or, you know what, this thing zings all the way into my toe. That's sciatica pain. And there are many different causes for sciatica pain, but the major cause for sciatica pain is a disc herniation or a disc bulge, right? And so I have a little model here, so you can probably see it. I don't know if you can see it here, but typically what happens with sciatica is with time, usually past the age of 30, all of our disc spaces will start to kind of degenerate. And as they get weaker, what ends up happening is all it takes is one pull, one fall, one accident to cause these discs here to kind of rupture, right? So the outer part of the disc is very strong, which contains the gel, which allows for shock absorbance. Well, when the strong part starts to get weak and it kind of forms a small little hole, some of that gel starts to come out, and it causes inflammation within the nerves themselves. Now, each one of these nerves radiates down the leg in a certain distribution. So a lot of times we'll ask, hey, is your pain going into the back of the leg or into the front of the leg? Because that allows us to figure out which of these disc levels is actually causing the problem, which ones are the ones we have to target. So basically that's one cause of sciatica. Another cause of sciatica would be sometimes you get arthritic changes in the spine around this region here, let's say, right? And if you have inflammation within the facet joints here, it can pinch the nerve posteriorly as well. So any nerve irritation is going to lead to this type of sciatica type of pain. So I'm going to orient the spine here. Basically, this is the front of the spine and this is the back. So you're looking at a side view picture. I don't know if you guys can see it there. Is it looking okay? And so these are the discs, which are the shock absorbents. These are the bones, the vertebrae. Here are the nerves that radiate down the leg. And back here, you have the joint spaces of the spine. So let's focus here. So let's say your disc, you pull something, all of a sudden, I feel some back pain, but most of it is really going down into the leg. Well, this is most likely what's happening. You see that little red thing there? That basically is causing some irritation to that nerve, okay? So there's a couple of different ways of treating this type of problem. One is a more conservative approach, which is giving it a little bit of time, right? So let your body kind of heal itself. So your body has all these cells that eventually will try to minimize as much of the inflammation of this particular nerve as possible. And then you can also try to take an anti-inflammatory. Sometimes if you go to your primary care physician, they'll give you some a Medrol dose pack or something, which is a steroid that you take 5, then 4, then 3, then 2 per day. And that sometimes will help. But if it doesn't help, then we have to move on to the second step, which is called an epidural injection, right? And now what we use epidural specifically for sciatica pain. We don't use it for other types of pain symptoms, which we can discuss later, but specifically for sciatica pain and radicular pain, which is pain in the leg, we end up using epidurals. And there's different ways of doing epidural injections. You can do the transforaminal approach, which means we go in here directly, okay? Or you can do the classical approach, which is intralaminar, which is midline right in here. Or if all of this is pretty messy, let's say you have severe spinal stenosis, or let's say you have a lot of instrumentation there from fusions, then what we end up doing is going through here, which is the caudal approach, which shoots the medication upwards this way, okay? You know, they're all pretty effective, but the whole reason we do this is to really try to minimize inflammation as much as possible, because when you have inflammation of these nerves, it starts with pain, but then you can advance to numbness, tingling, and then it can advance to weakness. And once you get to that weakness part, that's kind of like the last stage. It may be hard for an injection to kind of fix that problem, essentially. So you want to try to get treatment as soon as possible. You want to really get it to the point, at the point where it's an acute type of problem, meaning within the first 4 weeks or so. Because if you let it go and it's been 6 months and you've tried this, you've tried that, and nothing has worked, then you know you're looking at an injection maybe not giving you as much response as you would like. You might need a second injection as well. You know, so these are things that we would sit down and talk about and kind of go with the prognosis of what this injection would do. So an epidural is done under fluoroscopy, which is it's a big X-ray machine, basically. And it allows us to visualize exactly where we're going to go, right? So I can see your spine basically live on a monitor, and then I can also see where the trajectory of the needle is going to go. The other thing that we do when we do epidurals is we inject a little picture dye. It's a contrast solution, but it's only a tiny amount. And the reason we do that is because you want to verify the flow of the medication. Once you've verified that you're in the epidural space, then we inject the actual medication, which is a combination of lidocaine, numbing medication, with cortisone, which is your potent anti-inflammatory medication. And that typically, when we're doing that, sometimes you may feel a little pressure going down the leg at the exact location of where the pain is, which is nice because then you know, okay, you're on the right spot. And then immediately after the procedure, sometimes the leg can feel a little wobbly for the next 5 to 10 minutes because of the lidocaine, but then that basically wears off and you're good to go. The cortisone in the solution typically takes anywhere between 1 to 5 days, right, to really start to work and kick in. And we have patients that the next day they feel amazing. And then we have other patients that, you know, they're like, oh, I don't think this thing worked. And then day 4, day 5 comes along and all of a sudden it's like, wow, this is good. So I usually tell patients, look, give it about 1 to 5 days. And for the first 3 days, even if you feel amazing, don't do too much. Take it easy. The other thing that we should do when you have sciatica pain, after we've taken care of the inflammation, is exercises, right? So in order for us to improve the core muscles, because the core muscles are what keep everything nice and stable, okay? What we need to do is make sure that we're doing the appropriate exercises specifically to target sciatica pain. Now, these exercises, what I typically do is I would send you to a physical therapist to teach you the correct exercises to do specifically for your condition, but also how to do them. Because what I do see a lot is patients go on Google or they'll watch a video or something and they'll try to mimic it, but they don't have that feel. So sometimes you can actually make things worse, or you can hurt other other structures like your hip. I've had patients that come back with hip pain after they try to do some exercise. So I always say, go see a physical therapist. I refer to physical therapy a lot, maybe for 4 or 5 sessions, just to get to know the exercises, and so that you can really know that you're doing it correctly. And then after that, it's up to you. You do it at home, and we go from there. The other things that we can do for sciatica, let's say epidural doesn't work, would be to get a neurosurgical consultation, right? Because I want you to understand that what we're doing when we do epidural injections is we're minimizing inflammation, but that disc is still bulged. That disc is still kind of weak, right? So if the epidurals aren't working, physical therapy is not working, the medication hasn't worked, then we need to go and, send you to a neurosurgeon to find out if this is a structural issue that actually has to get fixed. And there's different surgical procedures that they can do. The other thing is, if you're not a surgical candidate, if you don't want surgery, or surgery is just very extensive, and you decide, I don't know if I want to go through surgery, there's another thing we do called it's a spinal cord stimulator. And what a spinal cord stimulator is these little leads that we put inside of we implant it, but you got to try it out first. It's a trial first and then implantation. But these leads go into the epidural space, and what they do is they basically mask the pain. So the structural issue is still there, but what we're doing is, with these little leads going into the epidural space, what we do is, instead of you feeling that burning sensation, that deep aching sensation in the leg, you'll either feel sort of like a little vibratory sensation, or now with how technology is now, you might not even feel anything at all, right, as far as pain is concerned. So those are some options that can alleviate sciatica pain.
Awesome. Multiple ones, which is great. And these are available too, like the injections and everything. You do those at your office, correct?
Yeah, these are done here at our office, again, under, image guidance. So nothing we do here in our office is just by feel and injection. Even when we do trigger point injections, which are injections within the muscle tissues, we use ultrasounds to make sure that we're getting to where we need to, the correct structure. But everything's done here. And as far as sedation is concerned, these procedures take about 5 minutes to do. They're not very stimulating, let's say. So it's not a very painful procedure, and it's a very quick procedure. And as long as you know what you're doing, the patient or you will notice that immediately after the procedure, you're just going to say, oh, that was it. Yep, that was it. I do give something to help relax before the procedure sometimes, because hey, no one likes needles, and you can get kind of anxious with it. But we put some music, and I talk, and we just kind of get it over with, and everything seems to work out very well. The only problem with sedation is the fact that there is when you have sedation like propofol, Reversit, or whatnot, there is some cognitive impairment that can occur, especially in patients that are over 65, 70 years of age. So you want to try to limit as much sedation as possible, and that's why for these small procedures, we don't need to use sedation. But yeah, everything is done here, outpatient setting, and so you don't have to go to a surgical center or a hospital to get it done.
Awesome. And tell us real quick where you're located and best phone number to contact you at, in case somebody would like to go ahead and give you a call and make a consultation happen.
We're located in Venice and Northport. Address is 1525 South Tamiami Trail for Venice. And our phone number is 941-237-0050. So if you guys have any sciatica pain or any other types of pain that you need taken care of, just give us a call and we'll get you in as soon as possible. That's the other thing is I try to get everyone in a timely fashion as soon as possible. Emergencies, obviously, we try to, add on, but I don't want you guys waiting more than 2 weeks out to be seen. Okay.
Awesome. Thank you so much. And I want to thank everybody for watching today and learning more from Dr. Omar at Family Spine and Pain Care Institute. Please reach out to him at the office and he'll take really good care of you. Dr. Omar, thank you so much and have a wonderful day.
Thank you. You too.